I'd just like to start by acknowledging the traditional custodians of the land on which we meet this afternoon, the Gadigal people of the Eora Nation, and pay my respects to elders past and emerging, and extend that respect to Aboriginal people that may be here in the room with us today. So, did you know that cervical screening can be carried out safely at any time during pregnancy? This is the key message that's being promoted to women, to communities, and also to primary care providers in a project that's been funded by the Cancer Institute New South Wales that aims to increase cervical screening during the antenatal and postnatal period for never screened and under-screened Aboriginal women and women from culturally and linguistically diverse backgrounds. We know that Aboriginal women and women from culturally and linguistically diverse backgrounds have significantly lower rates of participation in cervical screening. But why focus on the antenatal and the postnatal periods? Well, this is a time when women are accessing primary health care for routine antenatal checks, and provides an opportunity, a key opportunity, to review the need for cervical screening and, where appropriate, to promote or to provide that cervical screening. One issue for this project has been the lack of routine collection of country of birth or Indigenous status on the screening registers. So there is little data to guide the design and evaluation of our interventions. In this presentation today, I'll be talking about how we've used the data that is available to us, and that comes from a range of sources, and it's qualitative as well as quantitative data, and how we've used that to design and deliver highly targeted intervention strategies that have helped to determine the who, what, where, when and how of our interventions. In determining more specifically who our target populations are, we actually accessed cervical screening information that's recorded in a woman's statewide e-maternity electronic medical record at her first antenatal appointment with a midwife. In southeastern Sydney Local Health District, there were approximately 8,000 births in the year commencing the 1st of April 17 to the 31st of March 18. And there are 3 maternity services within southeastern Sydney. The rate for both Aboriginal women recorded at 68% and women from CALD backgrounds at 60% who were actually up to date with their screening was higher than what we expected when you compare it to the general population screening rate of 56%. And we're querying whether this may be due to self-reporting from women. When we look more closely at data, particularly for our culturally and linguistically diverse communities, we found that there were lower screening rates for particular groups of women, including women from Nepal, India, Bangladesh, Indonesia and the Philippines. Whilst the overall rates for Chinese women were higher than from other communities because of the large numbers of Chinese women presenting at those maternity facilities, actual numbers of women who were under-screened or never screened was higher. From this e-maternity data, we've also been able to identify those maternity services where there are women with lower screening rates and provide targeted education sessions to the antenatal groups of women that attend those facilities, with a focus on talking around women's health and cervical screening. So I'm hoping not to do your head in by this graph, which, as you can see, is rather wild and took us quite a while to make sense of. But what this graph did was help us choose where we should focus our interventions. What we did was match our census data to the New South Wales PAP test register information, and we identified 19 what we called hotspot postcodes in southeastern Sydney, where there were higher numbers of women of childbearing age from CALD or Aboriginal backgrounds. The 2-year period was 2014 to 16, and that was chosen to predate the changes from Pap tests to cervical screening, and a 2-year period was chosen to eliminate women who were returning for screening, and data was measured as rates per 1,000. So you can see that that data is very volatile with monthly fluctuations, making it really difficult to identify trend lines. But we were able to identify postcodes with lower screening rates or where there was a downward screening trend. And these were in the eastern suburbs, Botany, Mascot and Daceyville, Kingsford. Mascot was of interest because it made 3 lists in terms of high numbers of women of childbearing age, high numbers of called women and Aboriginal women. In the St George area, Arncliffe, Walleye Creek, Rockdale again was on 3 lists. Hurstville was on 2 lists, but at the top of 2. And in the Sutherland area, rates were generally higher, and most postcodes were trending up, apart from Miranda, which was trending down, and again, Sutherland made 3 lists. So responses on a survey that we distributed to primary care providers, and we had over 260 responses, and those primary care providers included GPs, practice nurses, midwives, child and family health nurses, enabled us to better understand perceptions of barriers to providing or promoting cervical screening during pregnancy and in the postnatal period, and to decide when should be the focus of our intervention, and that when is the antenatal period. What you can see is the most common barrier in the postnatal period for both providers and promoters was time to complete screening and concerns related to birth-related trauma, and they were factors over which we felt we would have little control. However, in the antenatal period, most common barriers were women's concerns about safety of screening during pregnancy and promoters' limited knowledge of the guidelines regarding safety of screening during pregnancy, and we've been able to design some intervention to address those barriers. Survey responses that related to confidence of primary care providers informed decisions about what the intervention should target. Whilst 68% of providers reported they were mostly confident or very confident to provide cervical screening during pregnancy, only 41% said they provided that screening for pregnant women most of the time or always. Free text responses on the surveys provided us with a lot more insight about this, and we heard a number of times that people were saying we were told not to do it in pregnancy, there's an increased risk of miscarriage, I don't want to be blamed if there's some complications around the pregnancy. The need to access guidelines regarding safety of screening during pregnancy or inaccurate information about screening during pregnancy was mentioned in free text responses 37 times in the surveys. What we heard in focus group discussions held with community workers who work with Aboriginal women and women from core backgrounds also shaped our intervention. From community workers who work with Aboriginal women, we heard that there was a strong community understanding of cancer and the rationale behind screening. We heard that barriers to screening included fear of bad news, shame, a really complex construct, distrust of government services. Enablers and strategies included community and family support and conversations, cultural safety, and services, particularly in services provided by primary care providers, supportive follow-up and Aboriginal staff were really important. In contrast, in focus group discussions with community workers who work with women from core backgrounds, we heard that for some cultural groups there was a very limited understanding of what screening actually was. You can see also there some of the barriers included a lack of accessibility to services and educational materials. But enablers and strategies included cultural brokerage, education, family and community support and in-language resources. In contrast to Aboriginal women, women from called backgrounds were reported to have a really high degree of trust in health, what health professionals told them. So putting together the who, what, where and when data collected for this project assisted in the how. And those how strategies you can see up there relate to increasing knowledge of primary care providers and increasing community understanding, and the strategies that we've employed there are listed under some of those points. Can I just do a last slide, which I'd just like to thank our the expertise and the support from our project team and our project partners in making sense of this data and in working on the project has been fantastic. So thank you.
So can I perhaps ask you to go back to the slide that you had to zoom through, because that's actually the interesting one. Yes.
Yeah, that's the interesting one.
So does anyone have any questions that they would like to ask? Okay, so that works nice. Oh, yes? Chrissy, hang on. Oh, Taz is coming.
Just in the slide before, I just noticed that it said barriers and I forget. Could you go back just the one before just to remind me?
Yep.
So barriers, fear of for Aboriginal women, it didn't come up as cultural safety as a barrier?
As cultural safety.
Cultural safety wasn't a barrier.
I've just listed a few. That was certainly something that came up, but was particularly strongly talked about as an enabler and strategy. So when we were theming this, it was like, where do you actually put that? One of the parts of the project that we will address with primary care providers is around providing culturally safe services. So
when you say primary health providers, is there is that Aboriginal health community controlled? Like, is there AMSs involved in that area? What do you refer to?
It's actually quite complex. So it'll be, we're working mostly with the PHN, so working with GPs in the community that are providing this service. In southeastern Sydney, we don't specifically have an AMS. Our local AMS is Redfern AMS, who we're not working directly with on this project.
So perhaps something to follow up on afterwards.
Yeah.
I'm going to keep us to time, so please join me in thanking Christina for her presentation.